Well, everybody, I'm Miguel Regueiro. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us today for this educational activity entitled The Medical Neighborhood in IBD, Steps to Improve Care for All IBD Patients. Today's program is supported by educational grants from AbbVie Inc., Janssen Biotech Inc., and administered by Janssen Scientific Affairs, LLC, and Takeda Pharmaceuticals USA, Inc. Today's activity is brought to you by CME Outfitters, an award-winning joint accredited provider of continuing education for clinicians worldwide. I also want to encourage everybody to join us on Twitter and use the live Twitter conversation at CME Outfitters. Again, that's at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs at the left-hand side of your screen and give us your feedback on the program and the platform as well. As mentioned, I'm Miguel Regueiro. I'm chair of Digestive Disease and Surgery Institute at Cleveland Clinic in Cleveland, Ohio. And let me first welcome my colleague, Dr. Ben Cohen. Ben is a co-section head and clinical director for inflammatory bowel diseases in the Department of Gastroenterology, Hepatology, and Nutrition, also with me at Cleveland Clinic in Cleveland, Ohio. Welcome, Ben. Good to see you, and thanks for joining. And I also want to welcome and thank our colleague, Dr. Maia Kayal, assistant professor at the Susan and Leonard Feinstein IBD Center, Dr. Henry D. Janowitz Division of Gastroenterology, Icahn School of Medicine at Mount Sinai, New York, New York. And for everybody, today is Maia's birthday. Ben and I were contemplating whether we were going to sing to her, but we are not. But happy birthday, Maia, and welcome and thank you for attending.
Thank you. Thank you for having me. And thank you for the birthday wishes.
Yeah, that's going to be tweeted out now. That'll go viral. All right. Okay, so let's look at our first learning objective. Our first learning objective is to integrate a team approach to improve overall outcomes in all patients with inflammatory bowel disease. Our second learning objective is to implement strategies to address disparities in care in patients with IBD by establishing trust, providing education, and engaging in shared decision making. So I want to start with a case, and we'll go through this and have some discussion. And in a minute, I'm going to ask the audience the first poll question. So this is Antonio. He's a 40-year-old Hispanic male. He immigrated to the United States from Central America at a young age, never completed high school. He visited the emergency room 3 times recently with IBD symptoms and reports significant weight. And this is a common scenario for kind of high utilization of an ER presence. In the ER, he was referred to a gastroenterologist, but the visit was delayed because of his limited English proficiency and confusion about instructions from the ED personnel. He's missed several days of work due to his symptoms, and he recently lost his job. He's at risk for losing his insurance. He reports feeling very upset and anxious about losing his job, and he started smoking more than usual. So before we move to the data, I'd like to get our audience involved and ask all of you this question. So choose one of the responses. What most concerns you about Antonio? A, his GI symptoms and weight loss. B, potential loss of insurance. C, concomitant depression and anxiety. D, health literacy and language proficiency. E, smoking. Or F, I'm not sure, which means we will teach you what we think in a minute. So go ahead and take a second to answer the question. And you could argue, and maybe in a minute I'll ask Ben and Maia, but there's not necessarily one correct answer. But what worries you the most? What would you be most concerned about? So we'll pull this up and we'll have the audience response here in just a second. And then Ben and Maia, I'll ask you kind of what your thoughts are. So the results are over half, 51% are worried about his GI symptoms. And then there's a bit of a mix between some of the others with 15% worry about his health literacy and language proficiency. Maia, maybe I'll start with you. Kind of what, are you surprised by the poll results? What are your thoughts? And maybe how would you answer the question?
Yeah, I think it's a tough question. I'm not surprised that the poll results are a little bit of each answer. I think, approaching this patient as a complete package of not only his GI symptoms, but also his socioeconomic situation with potential loss of insurance, his concomitant depression and anxiety, the health literacy, the smoking, it's really a whole package. And so it's tough to kind of pick one thing, even at this stage, to be most concerned about with Antonio. I think as GI clinicians were most inclined to immediately jump to his GI symptoms and weight loss. But I think part of what we'll talk about today is how it's really a whole picture and how we need to address every element of the case in order to really make a change in his outcome and his IBD care. So I think I don't really see a right answer. I think it would have been great if there was number 7, all of the above, but that would have given away the case.
Yeah, no, but I was just about to say, hearing you talk, I completely agree. If it was all of the above, probably most people would answer that. I think in a GI audience, it's not surprising that we always look at the symptoms first, but you really touched on some important pieces of information. Obviously, there's a health literacy, there's a language barrier, there's disparity of care. And now we have somebody who unfortunately lost his job, he has anxiety. So it's kind of this perfect storm. And I like the way you said we need to focus on the whole person. I think the days of us as gastroenterologists or IBDologists where we just drill down on the symptoms and kind of ignore everything else, those are gone. And this is something we're going to get into now in a minute. So perfect segue. Thank you, Maia. And I'm going to now kind of turn it over to Ben. And Ben, Maia really described this medical neighborhood, medical home model. And the case that we just saw is not really out of the ordinary for many situations that we encounter our patients. And one of the ways to approach the whole person care is by a team. And we use these terms, medical home and neighborhood that I mentioned. So maybe can you talk through how you describe a medical neighborhood model to our audience? How do you conceptualize this, and thinking about Antonio as well?
Sure. I mean, I think the way in the past that we practiced was really focused around the healthcare provider, and the healthcare provider focused on the IBD, and that was sort of it. But what we're seeing here is that there's a lot of factors that come into play that can impact the outcomes, whether it be those healthcare disparities, coping difficulties, pain, severe disease, health literacy, insurance coverage. And we can't take care of all that by ourselves. We need a team of people that are all working and putting the patient at the center of the care. And that's really the goal of the specialty medical home. And, if we talk about the specialty medical home, the neighborhood is really an expansion of the specialty medical home, incorporating the primary care providers, the social workers that may be involved, our colleagues in other specialties that may be caring for the patients if they have extraintestinal manifestations, if they need surgeries. So it's really looking at patient-centered care, then expanding it to population health and having all the pieces in place to take care of all the different factors that are going to play a role in disease activity, disease severity, and then other outcomes. And if we put all those pieces in place, then we can really focus more on quality of care for the patient and taking care of the whole person. And so this neighborhood model really talks about how all those pieces fit together and how we're all part of one team. And it's not necessarily the IBD specialist at the middle, it's the patient at the middle.
Yeah, and we'll actually come to some more concrete examples in a minute, more data, but the questions are starting to come in. And so those out there, thank you for sending the questions, and I'll try to answer them and have our faculty answer them along the way. So first of all, Maia, there are a lot of birthday wishes and birthday cake and other things that I'm seeing, but maybe I'll ask you, Maia, in New York and I know every region's a bit different, but one of the questions that came up, is it difficult to refer a patient to your specialty home or this neighborhood? Kind of talk us through how you do that in New York, or how you would conceptualize this. knowing that a lot of our caregivers out there are not in our tertiary or quaternary centers. They're in communities seeing these patients.
Yeah, I think, that's a great question because it's all about accessing the right resources for our patients and making sure that you're getting the patient to the specialist that they need to be at. At Sinai, we have a setup where all of our patients are referred to one central coordinator who then can put the patient in touch with the IBD home. And what we like to do is kind of ease the patient into the IBD home so that they're not overwhelmed with the number of visits that they need to, go to, so that they're seeing, for example, every element of the IBD home and every person responsible for that element on one day. And I think that helps in the sense that it makes it easier, number one, for the patient. By having one coordinator, it's easier for the physician to contact that coordinator and then know that they're responsible in getting the patient the resources that they need. And it helps the patient to see everybody as a team on one day. And so what we like to do is these patients are discussed at a weekly conference and then sent to the specialist that they need in order. But we really have typically a day where the patient comes in and meets every single person that's involved in the IBD home. And there's different, like Ben said, it's really a support system for patients. It's a place they can hang their hat. They know that they belong and they have the resources that they need and they can access them easily. And by having one central coordinator, it makes it very easy for the patient to touch base with that person and know that they're well taken care of.
Yeah, so almost like an air traffic control, somebody who kind of oversees everything. And I do think that that's central to the medical neighborhood, medical home. One of the questions that came in, and maybe Ben, I'll answer this, but then I'll segue into the benefits of the medical neighborhood and let you kind of take it from there. One of the questions is we're using terms home and neighborhood, and I'm guilty of not really defining these concepts. And the way I look at it is, the medical home is essentially, like Maia said, it's this group or this team. It's not a brick and mortars place. It's a team of people in different areas: behavioral health, dietitians, pharmacists, gastroenterologists, surgeons, et cetera, that really come together to take care of the patient. And a lot of this can also now be done through telemedicine. The medical neighborhood is really an expansion to all of you. So all of you out there that see patients in the community. And the neighborhood approach is, how do we interface together and work together? A lot of our patients don't want to travel a long way, want to stay locally with you, the gastroenterologist, the caregiver, the APP, but then use some of the resources of the neighborhood. And we've done that a lot through telemedicine. And I think, Ben, maybe you can talk through some of the benefits. What are some of the benefits of a medical neighborhood? You kind of started to touch on that, but let's understand that a little bit better.
Sure. And I think the key here is that we can think of the medical neighborhood as a partnership, not just within our own centers, but with the community at large. So we can work together to jointly manage patients so that we can help those patients that may be far away get some of the benefits that we'll talk about in terms of maybe nutrition care, behavioral health care that may not be available close to them, and work with their local team of gastroenterologists, primary care providers, so that we can partner together in the care of that patient. And when you use the specialty medical home or the medical neighborhood model to really approach the patient, some of the benefits we've seen, Miguel, from your work and also from the work at Mount Sinai, is that it really gets to decreasing unplanned care for the patient. So avoiding those ER visits and hospitalizations that are major cost drivers, and also potentially lead to bad outcomes for the patient, decrease their quality of life, take them away from work, reduce their ability to earn income. And if we can reduce those unplanned care and get better control of their disease by improving their behavioral health, their compliance with medication, their education around their disease state, that will ultimately lead to decreases in their disease activity, which I think you've shown from your work when you were at Pittsburgh, and also that's been shown at Mount Sinai. And when you manage populations as a whole and really focus some of these resources on the high utilizer patients, you can ultimately decrease cost of care, because I think what we've seen in multiple health systems is it may be fewer than 10% of the patients that are driving 90% of the costs. So if we can really get to those patients, get them the whole patient care they need, then we can really reduce overall cost to the system and take better care of patients.
Right. And then one of the questions, actually, I think this might be on your next slide, and somebody just said chatted in, so I'll ask this. So what do you need to create a medical neighborhood? So maybe kind of elaborate on that. And then Maya, I'm going to come to you because there's a lot of questions on kind of who is part of this team. And I think you have a nice slide coming up. But Ben, what do you need to create a medical neighborhood?
I think number one, you need providers that buy into it. So you need the physician champions, you need the other members of the team to really acknowledge that not one person can take care of the patient, that we need to work together and take a team approach to the patient. And to me, that's the number one thing in terms of the mindset of the team approach. It's important to have payers that are going to partner in this, because there is a cost to being able to have these services available. And you have to have the long-term vision that an investment up front is going to really pay off down the line for the patient. You have to have a high need population, which we obviously do in IBD. It's high stakes for them in terms of cost of care and also health outcomes. You ultimately need to be able to show that these interventions working as a team can be measured as success. So showing that we can reduce ER visits, hospitalizations, improve outcomes, and ultimately reduce cost. And I think it keep coming back to team. It's really about the team. We have to work together. You have to identify the people in your own center that are important to taking care of IBD patients. And then we have to have outreach to the community so that we connect with each other, whether it's through programs like this, to recognize, okay, if I don't have certain things in where I am, where can I meet people who can maybe fill those gaps, and we can work together to take care of the patients.
Right. So wonderful overview, and team. Maya, let's talk about the team, and I like I think on the next slide there's kind of this concept of how this looks. So talk to us, who's part of the team, and then I'm going to ask you a couple of the questions that were chatted in about this, because I think they're really, really important. But who is part of this team?
So, as you can see in the slide, the patient is really at the center, and everyone is, orbiting around the patient, which is important as a team. And we can start with the clinicians at the top, so the gastroenterologist and the primary care doctor. These two work together to really coordinate the patient's overall health, including their healthcare maintenance. We then have a very important member of the team, psychologist, and the psychologist in the IBD home or neighborhood really addresses mental health, coping skills, something that's very important in our resiliency training for our patients with IBD, because as you know, it's a chronic illness and patients have ongoing issues, including anxiety and depression, that need to be addressed before their IBD can be well controlled. Nurse is another very important piece of the team and piece of the puzzle. Our nurse is a very big source of education and training for our patients, particularly for patients who are about to start a medication, who need injection training, who need a very close follow-up in terms of adverse events related to their medication, frequent labs. Our nurses are a very, very big source of information and helpful part of the team. The social worker works hand in hand with our psychologist in addition to the other team members. Our social worker works to identify resources for the patient and the patient's family, and can assist with housing and transportation resources, and can actually serve as another very important point of contact for mental health support in addition to the psychologist for patients. You can see as I'm going through the different members how each member really builds on every other member, because it really is, as Ben said multiple times, a team approach. Our dietitian focuses on nutritional care and very importantly helps dispel a lot of the rumors that are out there related to IBD and diet. And so I think a very important piece of this is the dietitian just sitting with patients and talking about what's true out there and what's false in terms of diet on Google. Our pharmacist focuses also on medication safety education, similar to our nurse, but then also talks about vaccination coordination, tobacco cessation programs. And we end up back at the gastroenterologist and the primary care provider. And so as you can see, just this quick overview, everybody really works hand in hand, and each position builds upon the other person's position.
Right. And I think you kind of hit on some of the key questions that are coming in. I'm gonna actually answer this one because I saw several variations of this as you were talking. And a medical home sounds like a huge undertaking. And the question is this really realistic for the majority of community gastroenterologists or physicians? And The answer is probably not, to be quite honest. And I think that's where Ben was alluding to this neighborhood concept. And I think something that we're evolving to, and as I think about care models going forward, is that you're going to have this national ability through virtual or telemedicine. And I know there are barriers with licensing and some of those aspects, but I think we're going to overcome those in the near term. So there may be a patient, I'll use the Ohio model, for example, where we're in Cleveland, somebody's in Columbus or Cincinnati, and the patient sees us as this medical home Maia kind of outlined. But then the virtual care follow-ups, maybe pick the dietitian or the psychologist, and the patient stays with their community and local team. So I don't think each area is going to build this. I don't think that's practical, and I agree with the question. But I think through this ability, through virtual and telemedicine, we can do this. The other aspect of this, and I kind of quickly touched on, is pediatrics, which we talked about the other day, and Dr. Jen Dotson with us. Really, the concept, I think, is going to start in pediatrics. And we covered this the other night, but pediatrics has unique needs, not only from a dietary standpoint, but also from health maintenance, from psychosocial interventions and transitions of care, which we talked so much about the other day. I already mentioned how we create a medical neighborhood. And again, I don't know that this is where all of you are hiring a dietitian, the psychologist. Also, some practices are starting to do that. But I think, Maia, your point about this is an entire team and how we create this to get this total care, and having this referral for total care is just so important. I do want to touch on, Maia, the concept of disability, because Antonio was, we left him, unfortunately, he had lost his job. And then we look at disability. Talk to us a little bit about disability and IBD and how disability can impact IBD.
So, IBD is associated with significant disability. And actually, the absence of disability was most recently included as a treatment target in the most recent updates in STRIDE 2 guidelines, just to show you how important it is for our patients to really go back to a near normal baseline of life without disability. And so part of the IBD home, which is really nice, is that it is patient-centered IBD management. And this encompasses recognition and management of personal, environmental, and social factors that impact disability, and that may require a multidisciplinary approach. And so we know from multiple amazing studies that have been done that active disease, steroid use, unemployment are all actually associated with higher disability in our patients who have IBD, and therefore may impact their presence at work or school, and may impact their ability to perform activities of daily living, such as picking their kids up from school or going to the grocery or even going out for a walk. And we actually know that disability even extends further after IBD is well managed. And this might be associated with untreated anxiety or depression.
Yeah, and I think some of this gets to, as I see the questions come in about behavioral health, and the impact, Antonio right now is having depression and anxiety. And I think one of the areas, Maia, that you mentioned is sometimes the care of these patients can also be done by a clinical licensed social worker, a psychologist. One question I'm going to ask you is there a role for a psychiatrist, and how does a psychiatrist play in to the medical home, and kind of how do you look at that?
I think the role of the psychiatrist is very complementary to the role of the psychologist. I think a lot of times our psychologists are amazing and they focus on cognitive behavioral therapy and coping strategies and skills and breathing therapies for our patients. But at times our patients do need a psychiatrist to talk about other alternative medications that might be necessary to treat underlying depression, anxiety, or other mental issues. And so I think it's complementary. I don't really think it could be one or the other. I think that there's a time and a place and a role for both.
Yeah, and I think the only common or practical point to make too is that the access to psychiatrists now has become sometimes challenging given the number of patients they're seeing. So in terms of access with a social worker or psychologist, as you said, it's completely complementary. It doesn't mean to replace. You started to touch on a little bit shared decision. So talk to Maia about shared decision, and then Ben, we're going to get into a little bit about patient education And keep your questions coming because we are going to get through as many of them as we can.
So shared decision making is really the process in which patients and clinicians work together to make decisions and select treatment plans and tests and care moving forward. And the process balances the risks and the benefits of the decision with the patient's preferences and their personal and core values. And so it's an amazing process because not only does it empower the patient, it actually also increases patient and physician satisfaction. It improves patient and physician communication and has a positive effect on everybody's outcomes. So it's great. And it's a key component of the IBD home and patient-centered care. And so it's something that, we utilize every day truly in practice.
Yeah, and I think a lot of us probably do it. And I know those out there do it all the time. And we don't really think about it or say or call out shared decision, but that's how we practice. And that's part of communication. Ben, Antonio, we were talking about some health literacy and understanding and education. Maybe you can talk to us a little bit about patient education in IBD and how we should approach that aspect.
Yeah, I mean, I think this is a critical part of what we all do. I almost view myself more as an educator than a doctor, because so much of what we have to do in IBD is sort of assess the knowledge base of the patients about their disease, about the medications they may be using, and then really educate them about the importance of compliance. In order to do that shared decision making, they need to have information. So we have to provide them information. We have to understand where they're coming from and what the barriers are in their lives, and treat each person as an individual, and then work with them through that shared decision making and the education we provide about the potential outcomes of their disease, depending on which treatment path they choose, to help them find what's right for them. And we live in a day and age where information is available, but not all information is good information. So it's really important that we direct them to high quality resources to learn about Crohn's and ulcerative colitis, so that they are making healthy decisions for themselves. And I think there's a lot of research showing that patients are empowered by education and learning more, and that's going to lead to better outcomes, better quality of life, when they feel that they have control somewhat over their disease and the treatment path.
And one of the parts of education is obviously clear communication. And I really like a question that came in around the role of a translator. And Ben, maybe I'll ask you this. So comment on the need to make sure patients have access to a certified translator, and that we should really be sensitive and understand that it's not really appropriate to have the family or a friend translate. The medical translator is such an important part of the team, and actually I think in a way I'm at fault, because I think we could probably include the translator in this medical home paradigm. And I know we use them here in Cleveland and others, but Ben, talk about the medical translator and when you were in New York and now in Cleveland, how does that work?
Yeah, I mean, I think it's a skilled profession. So, that's why we can't rely on family members who may not have the health terms to be able to describe what we're trying to tell the patient. And there can definitely be something lost in the translation if we're relying on people who are not professionals in terms of this. So it is really critical to use a translator. I think sometimes the barrier may be that it's going to take a little bit extra time to call up the translator if they're not there with the patient, and wait for them on the line. But at the end of the day, it's going to pay off in terms of the patient understanding of the treatment plan and their disease. It will ultimately lead to better outcomes and fewer questions and gaps in care later on if we make sure we do it the right way from the beginning. So I think it's really important to take the time and to assess. Sometimes a patient may speak some English. You may not recognize that there is a gap in their understanding of the language. So it's also important to just ask the patient if they feel comfortable, and make them aware that we have these services available to them if they need it.
Yeah, just so important. And thanks for highlighting that. And thanks for the question as well. All right, so let's go back to our case. So just to recap, Antonio is a 40-year-old Hispanic male, immigrated to the US. We talked about he came to the ER a lot. He was having symptoms. has limited English, and Ben kind of already alluded to that. And unfortunately, wasn't really understanding what was being told of him in the ER. He's been missing work and now is out of work because of this. And he's feeling upset and anxious. And now he tells you that he feels completely overwhelmed and that visits arranged with the team in the medical home. So he actually hears about this program. We didn't put it on the slide, but I think it would be appropriate to say a translator was provided. He understands this concept of team and now really wants to come in and see the team. So let's get to our next audience response question. And I'd like to ask the audience this polling question. How would you address Antonio's issues in the medical neighborhood? A, treat his IBD. B, refer to nurse to address his smoking. C, refer to the social worker to address insurance issues. D, refer to the psychologist to address mental health issues. E, all of the above. Or F, I'm still not sure and continue to teach me. So I think Maya, unlike the last one, we have an answer that you might be happy with, but I'm curious to hear what people say. All right, so kind of predictable, right? So Maya, you were asking before for an all of the above. What do you think about that answer?
I think that is the best answer for this. If this was a board question, you always go with all of the above. And I think in this question, it really does highlight that we have to focus on Antonio as a whole patient, as a whole package, and address every part of his presentation. His IBD is very important, but we also need to talk about his smoking. We need to talk about his insurance issues because they're going to be related to how he's feeling. We have to get him in with one of our psychologists. So I really think that even though you always are supposed to go with all of the above, it is the most appropriate answer here.
Yeah, and I think you touch on this, and I think if we transition a little bit more to focus on how do we reduce healthcare disparities, especially for underrepresented patients, and I think Antonio's case really speaks to this. And I know you were mentioning this and covering this earlier, but how do you approach this? And again, I think Antonio's case really drives that home.
I think the first way to approach reducing health disparities for our underrepresented patients is by addressing it head on. So if a patient needs a translator, making sure that that translator is available so that you're reducing the first barrier of language, which is kind of the most basic barrier. And as Ben said, sometimes patients, you think that, they're speaking a little bit of English, but you might overestimate how much is actually being understood. I know that it happens a lot sometimes, and we really need to take a step back and make clear what does the patient need at a basic level to really carry on a clear conversation. I think addressing health literacy is important, really understanding the patient's background, where they're coming from, and what education they have, up to the point where you meet them, because that plays a big role in understanding what they're going to gather from the data that you're providing as part of shared decision making. Addressing health insurance barriers, that's where our social workers come into play and are excellent. Identifying resources that can help the patient in ensuring that they have regular insurance and have access to the medications and the visits that they need. Helping our patients with work constraints. A lot of our patients might need letters just to come see you, or for their scope, or for their MRI, for any procedure or test related to their care. And so working with them to make sure that they have that coverage, because they don't want to lose their job. And as part of the IBD home, we need to understand that that's part of the patient-centered care approach, and acknowledging, how we can make sure that they stay employed. And then hand in hand with financial constraints, right? As long as they're employed, hopefully we're easing some of the financial hardship that they might have. And so I think the biggest way to reduce health disparities is to address all of these issues as part of the visit, as part of the IBD home.
Excellent. Again, back to that team concept and really understanding and recognizing that. And across the country, I think this is something that we see every day and we need to be aware and sensitive to. We're going to get to your questions in just a second. I'm going to just recap, though, our SMART goals. And then we have definitely some time for questions. I'm going to ask both Ben and Maya. So in terms of SMART goals, we need to recognize the team approach for the care of the patients, as we've already really covered nicely, I think, in this conversation, utilizing this concept of medical neighborhood to link to primary care, to GI, and provide optimal care, where a lot of times the patient can stay in their community and work virtually with this team. Shared decision making, I think we do this every day, all the time, but I think it is important to hear the patient's voice. And how do we then integrate strategies to address underrepresented patients, as Maya was just so nicely summarizing. And then regular communication. I mean, I think we're all acknowledging this is an important part. So to ask a question, again, you can please click on the Ask a Question tab, type your question. You can include the faculty's name if you want, but most of you are just texting in or chatting in questions, and that's fine. You can keep it not specific to any one of us, and we'll get through them. So let's jump right into the questions, and then we'll come back to a couple closing slides at the end. But I think, well, so there are a lot of compliments on the program, but let's get to a couple of these questions. So Maia, you talked about disability, and when you talk about disability, how do you define that in a way that we can document it in the EMR? I mean, this is it's an important question. And how do you do that? How do you do that in your clinic or in New York?
That's a great question. And I think it's very important and relevant because absence of disability, again, is becoming a treatment target for patients with IBD. So we actually use the IBD Disability Index, which is a validated way to assess disability. It's a numeric score, and it's actually available online. Just Google IBD Disability Index. And it's a 16-point questionnaire where you ask the patient each question and they rank the answer on a scale of 1 through 5. You tally the score and it gives you an objective assessment of disability. And the questionnaire focuses on different features of the patient, not only their symptoms such as abdominal pain, stool frequency, rectal bleeding, but it also focuses on how supported did they feel in the last week? How able were they to accomplish their activities of daily living? Do they have any issues with their medications, securing their medications, securing the support for their medications? And so it really hits on multiple features related to disability, actually in a multidisciplinary way, which is very nice. And that's how we're documenting the IBD Disability Index. And actually, we've performed studies using the IBD Disability Index here in New York at 5 different academic institutions that showed that socioeconomic, social determinants of health were significantly related with higher levels of disability using the IBD Disability Index. And so that's what I would use to objectively document disability in patients with IBD.
Yeah, and it's actually pretty simple. It's not a cumbersome tool, and now that we integrate more in the electronic system, I think that's helpful. Ben, there was a question about, actually this is a Cleveland clinic, but it could be in New York. We didn't realize that we could access the Cleveland Clinic medical home through telehealth. Maybe Ben, talk a little bit about how we expand globally into this neighborhood, and not only how we do it here, but in other places as well.
Yeah, I mean, I think it's about creating partnerships with the community. So, you know, when you refer a patient, it doesn't mean that you have to refer a patient to not be your patient anymore. You can send a patient to see us for an evaluation with the clear goal of plugging them into the aspects of the team that you may not have available where you are. So sending the patient for a nutrition evaluation and resilience training. And then, you know, we may see them as a gastroenterologist and then just be the facilitator to get them to the aspects of our neighborhood that they need, and then be able to send them back to you for their local care of their IBD and be here as a resource. There's also alternative models where you may send the patient and say, you know what, we don't have a clinical trial that the patient needs, and you can send them so that we can help manage them and get them to a clinical trial they need. There's lots of different frameworks that this can be done, and the key is to have good.
Right, and there were, as you were talking, there are some questions about costs that came in, and maybe I can field a couple of these. What are the costs for patients or providers referred to you? So I think there are really 2 models if I were to simplify it. One is the integrated health model. So I'm going to say names of systems just to give you examples. So this would be like Kaiser Permanente, Geisinger, UPMC, where I've been before, models, and we could have a discussion whether that's where we're headed or not. If you're in that model, it becomes very centralized because it's within the same system. The model that I work in now, and probably most people work in, insurance companies are paying for psychologists and the dietitian. So you can access the care. The patients are actually, for the most part, achieving this benefit. I will say, and there was a question on Medicaid, Medicare, that some of the services are not covered. And then it depends on the medical home. So for example, there are patients where there are certain services like our pharmacist, I'll use that as an example, where we think it's important to have our pharmacist with us, but it's not something we charge the patient for because we know that sometimes that cost won't be realized. But we think it's important. We, Cleveland Clinic, our medical home, and I know Maia in New York, similar type of thing. And so we almost provide that service free, if you will, to the patient. The other question is, how do you see reduction in costs in a medical home or a medical neighborhood? That's a very good question. I'll be honest, I think the total cost of care may go down a little. I was hoping that we would have published to show a big cost difference. We do see utilization go down, ER and hospitalization, which are big cost drivers. So yes, we see that. But the cost itself, when we look at it, is decreased, but probably not as significant as the improved quality and the long term. So potentially having patients stay out of the hospital, stay away from surgery, some of those aspects as well. Maia, I'll ask you maybe a quick question. And none of these are quick questions, but I'll try to ask you one, then Ben, maybe one for you, and then we'll probably wrap it up. So Maia, I think you mentioned diet, and there's a lot of diet questions. I know you're not a dietitian, but just on a kind of a global microbiome, but what diets are you looking at in your IBD patients?
Yeah, that's a tough question because the data for diet and IBDs hasn't been great. I think literature is that a lot of our patients were really afraid of fiber and we're doing everything possible to avoid fiber. And we saw from a great study from Maria Brew that a high fiber and a low fat diet is actually great for patients with IBD, specifically for patients with ulcerative colitis. The jury's still out, of course, for patients with Crohn's disease, but in that situation, it's more of a mechanical issue if they have strictures. And so the biggest thing that I've been telling patients when I see them in the office, first is I actually go through their diet in great detail because we know from other data that patients with IBD actually have very high rates of micronutrient deficiency because they're avoiding so many foods. And so the first thing that I do is go through their diet in great detail. And then I actually start talking about liberalizing their diet because a lot of these patients are over restricting their diets. And so we start talking about reinserting foods that have fiber and that are low fat. And then I typically, that's the perfect segue to our amazing dietitian who does a way more in-depth job. But I think the first thing that I do is just talk about liberalizing their diet. I talk about the great benefits of fiber, even outside of IBD perspective, amazing benefits to fiber. They nourish the microbiome, promote lower rates of colon cancer. So fiber is great, everybody. Take your Metamucil. And then I talk about kind of a low fat diet, which of course, ultimately is great for cardiac health. So it's really just all the aspects of health overall, but that's what I've been telling patients more recently.
Sometimes just even simply, I'll tell them if you do one diet, do a Mediterranean. That's just the reality. All right, Ben, last question, and then I'll wrap it up. There were a lot of questions on nurses and APPs, which are so important in the medical home. Just maybe briefly, how do you integrate the nurses and APPs in our medical home?
Yeah, I mean, I think, again, it gets to the team and who are the members of your team. There are a lot of IBD patients out there, and it's going to be hard for any one of us to be able to take care of everybody by ourselves. So when we first meet a patient, we really hone in on that team approach and introduce all the members of the team, as Maia brought up earlier in the presentation. And that includes introducing the APP and saying that they're going to be part of your care. So we may alternate visits where I'll see the patient one time, sort of set the treatment plan in motion, and then the APP may see them the next time to do the monitoring visit or the care of the patient. So in order to expand our reach to more and more patients, we need to really incorporate advanced practice providers, and we need to also educate advanced practice providers so that they understand all the nuances of IBD care as well, because it's getting more complex. The more medications that come to market, the more complex decisions there are. and the more education is needed for everybody, including the patients and all of the healthcare providers.
Great. Well, so with that, I really want to thank Ben and Maya. Excellent program. That was a fast 45 minutes of discussion. I can't believe the time has gone by, and the number of questions that are still coming in are amazing. So that tells us we need to keep doing these programs. I also want to remind everybody that you can visit the Gastroenterology Hub for additional activities in IBD, as well as resources, animations, and patient education. And the entire series will also be in the GI Hub. And then finally, to receive CME credit tonight, complete the post-test evaluation. You'll be able to then download and print your certificate. But thanks for our audience. Thanks again to Maya and Ben. Hope everybody stays safe, well, and enjoys Thanksgiving next week, which has come very quickly this year. So have a good night. Have a good day. Hope to see everybody soon. Thank you.
Good night, everybody. Happy birthday.